All right, we're going to give everybody just a minute or so to get into the webinar. We just opened it up and I see the counter going up. And then we'll just start in about 1 minute when we have a few more people join. So hold tight. Hey, welcome everyone to today's webinar titled Financing Peer Crisis Respites in the United States. My name is Shoma Ghosh, and I'm an Associate Vice President at Westat. And Westat is an employee-owned corporation located in Rockville, Maryland. We do lots of federal contracting and work across the Department of Health and Human Services, including the Substance Abuse and Mental Health Services Administration, which is SAMHSA. I'm actually coming to you today from Appleton, Wisconsin, where I live. We've had 3 inches of snow today, so I hope that makes you feel better from whatever warmer location that you're joining us from. I am part of the leadership team for the SAMHSA Center for Financing Reform and Innovations contract. We call it CFRI for short because we always love our acronyms. CFRI is just a really fun contract where we get to produce reports, journal manuscripts, issue briefs, and all of these things cover really relevant financial issues around behavioral health and behavioral health services. We cover topics like financing peer recovery supports and opportunities for enhancing the substance abuse disorder workforce. We recently published 5 journal articles within the Journal of Psychiatric Services on the evidence base of school-based mental health promotion and prevention programs. So we do really important, fun resource development. I encourage you to go to our website, which is www.samhsa.gov/CFRI. You will be able to download our reports there. You'll be able to download and view previous webinars that we've done as part of our CFRI projects. And hot off the presses today, there is the report that we are going to provide an overview for you about during this webinar today, titled Financing Peer Recovery Respites in the United States. While you're on our website, while you're on the CFRI website, I would encourage you to register for our next webinar, which is going to come up on December 10th. And it's titled Financing Measurement-Based Care in Community Behavioral Health Settings. As many of you know, measurement-based care is a process where you use standardized, valid, repeated measures to track client progress over time and to inform treatment decisions. It's a really great tool that fosters shared decision-making with clients and providers and helps have joint decision-making lead the treatment and planning process. It's been shown to improve outcomes and quality care, and the webinar specifically will explore reimbursement options and potential financing solutions to increase the use of measurement-based care across communities. So, go ahead and register for that webinar when you get a chance. I am so pleased to welcome you to today's event. I've actually personally dedicated over 2 decades of my career trying to improve the behavioral health system, and this topic is really dear to my heart. I really value the role these programs play in our community, and I admire the staff who work there, who are the heart and backbone of these fantastic organizations. I personally, a few years ago, had the opportunity through a contract with the Assistant Secretary for Planning and Evaluation to go visit many peer crisis respite programs across the United States. And I have to tell you, I am a believer. I am awed and humbled by the work that's done at these respites, and I strongly believe every community should have one. They're a great resource. Today's webinar, we're going to go over the findings of a like I said, hot off the presses, new released SAMHSA report about peer crisis respites. And we're going to provide the overview of that. And then we're going to go into a panel discussion where you'll hear some important voices from the field of peer crisis respite, including some operators and founders. While we wait for others to join, and I see the counter for how many people are joining here going up, which is a great sign. As a matter of fact, we had 1,500 people, more than 1,500 people register for today's webinar. So this is an important issue. I think there's a lot of interest, and I think that's fantastic. As you will have noticed by now, everybody's chat is turned off for this event. And everybody's microphones and video are also off for this event. And that's just so we can have some high quality recordings of the webinar. The webinar recordings and slides will be posted on that CFRI website that I referenced earlier. And anybody who registered for this event will get notification when those are available. During the webinar today, we want you to ask your questions, and we want you to use the Q&A widget, which you should see on your screen kind of at the bottom. We want you to use that to ask questions of the speakers and the panel members as we move forward. If you're having any technical issues, if you can't hear the audio, video, whatever, also use the Q&A widget, because we have people who are monitoring that who can help you fix whatever logistics issues you might be having. All of the slides will be, as I mentioned, the recording, the slides, and the report will all be on that CFRI website. Check back and you'll be able to see them there. The report is there now, but the slides and the recording will be there within 10 days. During the webinar today, you're going to hear from Sarah Beeler, who will provide an overview of the key report findings. And then we're going to have a interactive panel session. Katera Templin will be moderating that session. And we have, as you can see on the screen, some exceptional panel members. I'm going to call out Steve Michio, who was so helpful to us and was instrumental in putting this report together. And you'll hear from him, but you'll also hear from Cameo Jones and Vesper Moore, and it's going to be great. But before we get to Sarah and the panel, I would like to introduce Paolo Del Vecchio to do some opening remarks. Paolo directs the Office of Recovery within SAMHSA, and I've personally known Paolo for over 20 years. I used to work at SAMHSA with Paolo, and Paolo has been amazing. He's led efforts across government to expand the availability of recovery support services, including peer services generally, but also peer crisis respite programs. He has over 40 years of experience in behavioral health as a consumer, family member, provider, advocate, and policymaker. I'm a big fan, and I'm so pleased that Paolo is able to join us today. So with that, Paolo, I'll let you take over.
Thank you, Shama. And on behalf of the U.S. Department of Health and Human Services, SAMHSA, and our Office of Recovery, I bring you greetings and welcome you to today's event. I'm grateful you can join us today for this webinar on peer crisis respites. As noted before, this morning, SAMHSA released Financing Peer Crisis Respites in the United States. This report is one of the first times ever that the federal government has published on this topic, and one of the very few publications examining how peer crisis respites operate and are funded. We've posted a link to the report in the Q&A that you can find at the bottom of the screen. Today's webinar, as we noted, will review the report's major findings and hear from peer leaders who are experts at starting and operating these innovative models in communities across the nation. This work aligns with our national recovery agenda that includes expanding peer services. I want to say, as a person with lived experience myself of mental health addictions and trauma, and one who's experienced crises many times, this issue is also personal. I'm certainly not alone. Currently, many people in this country are in distress, and people are looking for support in every community. We must have a no wrong door approach and provide individuals and families with choices of where to turn, and peer crisis respites provide individuals, families, and communities with an effective option during times of crisis, especially when people are vulnerable and need compassionate peer support. Before we dive in, we want to acknowledge the report includes information on 27 peer crisis respites across the nation with a focus on mental health. And though a small sample, it's an important step in learning from the peer respite experts in the field. So why now? In large part, because these programs work and are cost effective. Studies have shown that people utilizing peer-run respites are 70% less likely to use inpatient or emergency services and show statistically significant improvements in healing, empowerment, and satisfaction. They are also far less costly than other approaches such as ERs. States, to their credit, are increasingly recognizing this value, and have we seen these models beginning to proliferate across the US. Peer crisis respites are operated by peers, and it's important to stress that these are non-clinical programs that offer safe, voluntary, short-term stays in small, trauma-informed and supportive home-like environments that's quite distinct from emergency rooms and hospitals. Also want to stress that this report is not an end, but a beginning, a tool to start supporting community conversations to cultivate the growth of peer crisis respites. There's also a need for more information on long-term sustainable financing. More data and research is needed on effectiveness. There's a need to address issues of fidelity that's defined by the peer community. And there is a need to address how respites can best serve people who have unique needs, communities of color, LGBT populations, rural areas, and more. While this report primarily addresses mental health-focused peer crisis respites, we've also seen respites developing for people experiencing addictions, and we're going to hear from one of them today. We've also seen respites develop for family members, and we need to examine these unique models while promoting the need for whole health, whole person approaches. Peer crisis respites emerge from the peer community, and it's important that peers lead the way in shaping their growth and their future. That's why I am so thankful for the peer respite leaders who are participating in today's webinar, those who contributed to the report, and those around the nation that are doing this important work. I also want to thank our team at CFRI, contractor here, Westat, staff at leadership at SAMHSA, including those within our Office of Recovery. Peer respites ultimately offer people a place of refuge during times of struggle, a place where people can find hope and healing, a place where people can begin and continue their journeys of recovery. Thank you again for joining us on this journey. Shoma, back to you.
Thank you, Paolo. That was inspirational. Thank you so much. At this point, I'd like to introduce Sarah Beeler, who is going to go over the highlights of this report. The one that came out today, the one that we want you to go find on the CFRI website. And Sarah is a principal research associate at Westat and a lead on this project. She's a community psychologist and with over 10 years of experience conducting community-based participatory research and mental health services research. And with that, the mic is all yours, Sarah.
Okay, thanks, Shoma. And thanks, everyone. I'm so glad to be here, and I'm glad you've all joined us today, and I'm really excited to share this report. So first, we wanted to define peer crisis respites. Peer crisis respites offer voluntary, short-term, overnight stays for individuals experiencing a behavioral health crisis. They're community-based and staffed fully or mostly by peers, meaning people with lived experience of behavioral health challenges. They offer a supportive, non-clinical environment for individuals to navigate crises and regain stability. There are a couple key features that set them apart within the behavioral health crisis continuum of care. That is that participation is voluntary, as Paolo mentioned, and the services are peer-led, non-clinical, and focused on recovery, emphasizing self-determination and autonomy. And peer crisis respites are increasing across the United States. Next slide, please. So research has documented a variety of benefits and positive outcomes from use of peer crisis respites, both for individuals and for service systems. Some examples are on this slide and include improved functioning and self-esteem, increased satisfaction with care, increased connections with community resources and supports, and reduced emergency room visits or psychiatric hospitalizations. Next slide, please. Peer crisis respites play a unique and essential role in the behavioral health continuum of care, from prevention and early intervention before a crisis, to acute crisis services during a crisis, to post-acute recovery support services after a crisis. They are more than just an alternative to hospitalization. They help bridge gaps between outpatient services, community-based supports, and more intensive interventions like psychiatric hospitalization. Next slide, please. So we conducted an online survey of peer crisis respites in the country in the winter of 2023. We wanted to build on the series of surveys called Peer Respite Essential Features Surveys, or PREF, that were conducted by Live and Learn, Inc. every 2 years from 2012 to 2020. And we wanted to add questions on financing since that was the focus of our study. It ended up that over half of the questions on our survey were the same as those in the most recent 2020 PREF survey. One key difference is that we sent our survey to a broader set of peer crisis respites because we wanted to make sure we captured diverse perspectives and experiences, particularly around the variety of financing approaches. As Shoma mentioned, our partner on this was People USA, and we're lucky to have Steve Michio, the CEO, with us on our panel today. People USA is a peer-run mental health nonprofit that operates several peer crisis respites and established some of the first peer crisis respites in the country. They programmed and administered the online survey. The survey was sent to 82 peer crisis respites across the country, and we ended up including responses from 27 respites across 16 states. We received about 35 responses, some were incomplete, and there were a handful of responses from peer crisis respites that weren't yet open, but were opening in 2024. And so we thought we could follow up with those respites later. We did several survey reminders were sent, and we also conducted individual follow-up to non-responders, but unfortunately we weren't able to get more responses than that in time for this report. So while we hoped for more, this provides a starting point for future conversations among the community of peer crisis respite providers. Next slide, please. What we learned about the operations. So all of our respondents reported that most of their staff were peer specialists, and nearly 90% said that all of their staff were peer specialists. Most of the respondent respites were small in terms of beds, so all had 10 or fewer beds, and pretty small in terms of staffing. So about 80% had less than 10 full-time or part-time staff. Most of the respondents served under 250 guests in the year 2022 and reported having maximum stays of 6 to 10 days. Next slide, please. There were a wide variety of services that respondents reported providing across the care continuum for their guests, ranging from prevention and outreach to active supports during crisis to follow-up after guests left. The most common service provided was wellness recovery action planning, a curriculum used in the peer support group process to really support individuals in self-managing wellness and setting wellness goals. The second most common service reported were warm lines. Those are free, confidential phone lines that offer support and information. Those and other follow-up services allow the peer crisis respites to serve more individuals than the bed totals and limits would allow. Next. In terms of funding sources, our findings were similar to the 2020 most recent PREF survey results. So we found that the top sources of funding were state and local mental health departments, along with donations and private foundations. Most annual budgets ranged from $250,000 to $750,000, with the bulk in between $250,000 and $500,000. 6 peer crisis respites reported Medicaid as a source of funding. And so given this patchwork of relatively unsustainable funding, it's really important to think about how peer crisis respites can offer the best guest experiences regardless of the funding sources. For example, how can peer crisis respites ensure that lengths of stay are based on individual preferences and needs rather than funding restrictions? Next slide, please. We also asked about funding challenges, and among our respondents, the most common funding challenges were achieving long-term financial stability, misalignment of requests for proposals or funding priorities with the principles of peer support and peer crisis respites, workforce issues, and not having enough funds to cover the costs of services. Critically, a third of respites who responded reported being unable to count on their current funding levels to continue past 5 years. So that means they're facing a relatively short time horizon that makes it very challenging to plan. Next, please. So peer crisis respites provide a wide range of valuable and needed services within the behavioral health crisis care continuum. And they do this despite facing substantial challenges for sustained funding. While SAMHSA and others are recognizing that they make valuable contributions within the crisis care continuum, improving awareness of these critical resources among the public as well as traditional crisis response staff would be beneficial. Next slide, please. We acknowledge the important and ongoing work by peer leaders in the field to measure fidelity and identify core components. In addition to that work, other important steps include evaluating peer crisis respites, especially for recovery-related outcomes, assessing their cost effectiveness, and exploring how to expand sustainable funding. So our hope, as Paolo and Shoma mentioned, is that this report and conversation is a step toward increasing sustainable funding to expand peer crisis respites and help more people in need across the country. So thank you. And now I'll hand it over to Katera, who's our moderator for today.
Thank you, Sarah, for the summary of the new SAMHSA report on financing peer crisis respites in the United States. My name is Katera Aslami Tamplin. I'm a person in recovery from mental health conditions and substance use challenges, and I'm a public health advisor at SAMHSA within the awesome Office of Recovery team, which is led by our esteemed director, Paolo Del Vecchio. I have over 20 years of experience in the field of peer support, including running a peer-run organization, and had the opportunity to start up a peer respite in Alameda County named after Sally Zimmern, a pioneer in the mental health consumer survivor movement. So it's a huge honor to be the moderator for this webinar with our 3 incredible panelists who bring a wealth of knowledge to the field of recovery and peer support. Their diverse experiences starting up and operating peer respite programs are valued and hopefully one of many opportunities to learn from them and the growing peer respite provider community. Just to reiterate what has been shared previously, peer crisis respites provide valuable and needed services within the crisis care system of care. And it is one of our goals at the Office of Recovery to expand peer-provided services within every community. And without any further delays, I'd like to briefly introduce our panelists. For this webinar, we have Steve Michio, Chief Executive Officer of People USA, a peer-run organization who has operated peer respites for almost 25 years. Cameo Jones, Founder and Executive Director of Live Recovery Sober Living. She opened the first peer crisis respite in Missouri in 2022. And Vesper Moore, Chief Operating Officer at Kiva Centers and Indigenous leader promoting mental health and disability rights. Vesper has contributed to establishing mental health organizations worldwide, including several peer-run respites in the United States. So to kick off the panel discussion, I'd like to ask Steve, you've spent a considerable amount of time establishing peer crisis respites and thinking about their value within the continuum of behavioral health care. Can you tell us more about how they fit into the behavioral health crisis continuum of care?
Sure. Thanks for having me, and I appreciate being here. In the beginning, when we first had the idea of doing it, and I worked with Sherry Mead on the concept and some of the challenges or what to expect when, if we opened one, um, was proving the integrity of the peer respite. And it took several years, many years, for the traditional community to understand that you could run a house with people that had lived experience dealing with folks in crises, or close to crises, and provide better opportunities, better learning, better knowledge, and a better way of dealing with crisis in their lives going forward. So it took time for people to understand it. And once they did, when I say people, I'm talking about traditional providers, hospitals, police departments, everyone that is involved in our communities. They embraced it. They began to ask the question, why aren't these in every community? Why aren't these in every part of the state and part of the country? So it was really, I think the challenge really was building the integrity and trust of a traditional, chronically normal community, understanding that people like us with that lived experience and trauma can do something great and better sometimes in many cases than the traditional system has ever done. So that's, it's a very short answer to a very long process of getting the respites embraced.
Wonderful, and thank you for your leadership and also uplifting Sherry Mead, who's been a pioneer in this movement, who is a pioneer in this movement. And of course, focusing on the integrity of peer respite and the services. Thank you for that. And Cameo, this question's for you. So your work with peer crisis respites meets a critical need by addressing recovery from substance use conditions. What inspires you to do this work?
Hi, thank you. So I think I come from a different perspective. When our idea came to us that peer respite was so highly needed. I have been providing recovery support services and recovery housing in the state of Missouri since 2017. And we always noticed a gap when others would relapse or there were services that were needed that the recovery housing just couldn't meet. And I just at the time didn't know what that was. And then upon our education with the state of Missouri, peer respite is what crisis peer respite is what came into play. And at the particular time we opened up in 2022, Black men in particular were leading in overdoses in the state of Missouri. And that's where we opened our first peer respite program in North City, St. Louis, to help those individuals that were leading in overdoses. So that's where a lot of the passion came in creating low barriers and access to services and really opening up opportunities specifically in that community that was lacking services, lacking acknowledgement, and creating an environment of wellness and opportunity to getting the services that a lot of individuals were getting in other areas, and particularly in the Black community just were unaware of. Since in opening that respite program and working with other partners, that's what respite is collaboration and connecting, and collaboration and connecting with other partners in the area, the overdose rates have dropped 40% in North City, St. Louis. So your question is what inspires that work it's that right there. That's the inspiration of being able to get individuals connected, being able to empower our peers to give back to their communities that they come from themselves, and getting the access to services, and helping others around us, hospital systems, treatment providers, and others really buy into what Pure Respite and services are able to do, and getting them connected with them as well.
Thank you. That is very inspiring and clear that the passion to serve the community through, connection to other peers and, meeting them where they're at is leading this work, and it's very inspiring. Can you share more about what Peer Respite Services provide to communities that is unique compared to other behavioral health crisis resources?
Absolutely. So, I really love the fact that, what I've learned is every peer respite is different. It's unique to the community, and our community in particular called for this type of respite that we have. Um, so at our peer respite, we are able to provide obviously on-site peer support services. It is peer-led. We provide transportation, food on site, hygiene items and kits. They are able to get access to doctor's appointments, counseling sessions if need be. We're also able to connect them to, like I said, primary care physicians. Some are, coming to our peer respite program, waiting to get into inpatient bed because it's hard to get into inpatient beds at times, especially getting closer into winter, where they're going to be full. Well, that's where peer respite is able to fill that gap, and that's what peer respite is. It's a gap filler, and we're able to not only have to have individuals out on the street continuing to suffer from these environments, and not everybody knows about North City, St. Louis, but it's high crime rate. And so having our peer respite in that area is extremely critical, and now able to get them access to all these services is very important. And they're able to come in with absolutely nothing and leave with everything that they need to start their foundation, and whatever that looks like for them.
That's powerful and so, as you said, important. And you highlighted that the personalization of it, like really making sure meeting people's needs and goals and preferences to help them in their journey of recovery through peer-to-peer support is just as powerful as any other support that's out there. So thank you. And building on that, Vesper, Kiva Centers is an Indigenous-led peer-run organization, and you have experience starting and running peer crisis respites. You're also a nationally recognized expert in addressing disparities and providing peer support services. What strategies have you found helpful to promote equitable access to peer crisis respites for minority, underserved, and under-resourced populations?
Absolutely. I think it's an important question. And I think sometimes when we talk about even peer support itself, communities, a lot of Black and Brown communities don't always know that that's a voluntary, community-based resource. And I think it involves meeting in the community and clarifying that, and also being in places that are beyond traditional behavioral health environments. So like we hand out like flyers and brochures about our peer run respites at like powwows, community events. We're in laundromats, like making sure those flyers are up on bulletin boards that are in those spaces, where we try to be in the community. We're in barber shops and hair salons doing a lot of this work too. And I think a lot of folks overlook that. I think we're traditionally trained to, like in behavioral health spaces, to advertise here, to do the outreach here, when in fact you can do all of the outreach you want in the world, but if people don't have the transparency of knowing what this is, how it could help them, that's a voluntary resource that they can come and go from a peer run respite whenever they want, right? That it's run by people with direct life experience that know what it's like sometimes to experience these things, right? And then it's run by people in their community. I think there's a lot of power there. We've seen that work in a lot of the work. We've also ensured that everything that we have in our peer-run respites is as equitable as it can be for every community. We have some great resources, such as like hair kits for Black and Brown communities through a group called Depressed While Black. It's just the word depressed and then while and then black. And they make hair kits that and skincare, supplies that are specific to people with my hair type, skin type, and other folks. So I think also having that and just knowing that you're welcome and that people are really considering all of these things is so important and so detrimental to the work too.
Definitely essential, and I appreciate you highlighting again that the voluntary component, the community, being embedded in the community and representing the cultural needs and the nuances that really create a warm and welcoming and feeling of belonging. I think that's really critical. You shared people who've been there themselves that are working at peer respites are those that are sharing what they've learned along their journey and create space to support one another. It's very powerful. Thank you again for what you do. The next set of questions is open for all of you to jump in and answer and share your thoughts. And the first one will be related to the purpose of peer respites, which we know is to support individuals in crisis through principles of peer-to-peer support. What are some of the benefits for individuals who use peer crisis respites in your programs?
I can
Where
start
do you,
first.
go ahead, Kimmy.
Sorry. I can start first. The benefits for that I am seeing, I mean, the benefits are just endless. And the benefit is really whatever they need at whatever that looks like for them. Um, but the benefits that I'm seeing is sometimes individuals are just coming to lay their head, and that's okay. Some are coming just to for a reprieve and do not look to stop actively using, but just want a place to get sleep and rest and medications, and that's okay. And then there are others that their benefit is that they're getting access to recovery housing. We served just between me and the 6 other respites in the state of Missouri. We served over 3,000 individuals last year, and 2/3 of those individuals went to recovery housing. And then we also have individuals that benefited by going into inpatient treatment. The overall benefit that I have seen so far is access, and able to, as we said before, they are coming in with absolutely nothing at times, but they're leaving with something. They're leaving with support and connection, and even if they choose to go back out and continue to use, they're not going out with options and resources, and that ends up having them be able to come back again.
Yeah, to add on to that, I mean, the access is important, but it's also free. People don't have to pay anything to come to these respites. And the other piece of it is the way they're treated in our houses is very different from what they're used to. And we get the comments and testimonies so often where people say, who are you people and what are you doing to me? And nobody's ever said that to me before. Nobody's ever asked me those questions before. I've never felt so safe and comfortable in a place like this, even though I'm dealing with so many issues. It just empowers people. It lends the vision of hope. People find their personhood as they get to know that they're not alone, that they have a resource that they can come back to or they can communicate with 24/7. And the passion of the people that work for me is so powerful and so strong that it really lends to giving more than just hope, but giving people the opportunity to have a better quality of life for themselves. And many times the guests that have come to our house later become staff because they want to give back. So you're giving back in that way. You're giving back to your community. You're making it less expensive for communities. And I think we're in the beginning of shifting a paradigm, and I'm glad we're going to be talking about funding today because it's starting to open up and provide more opportunity for so many.
And if I can just add briefly, I think one of the most important things is that a lot of our guests say that they're used to being like having circumstances of being either involuntarily committed or ending up in an inpatient environment that doesn't fully like serve what they need, waiting in an emergency room behind like 20 other people, um, and often still having those needs unmet, right? From a financial perspective, too, the benefits are immense. But I would say for our guests, it's that life-saving component. They're not behind a locked door. They can come and go as they please. And I think that is a huge breakthrough in a lot of ways for what we've seen historically and in behavioral health.
Yeah, that's powerful, that trauma-informed approach that's focused on the strengths of people and creating that safe, not only physically safe, but psychologically, emotionally safe environments. And you highlighted access and big pieces like free, like you're not trying to create more barriers for people to thrive and find their personhood. That's incredible. Thank you. And we know also from the report that the studies have shown, that the positive outcomes that you're saying are validated. People are, post-crisis, they're being reduced in terms of the need for emergency room visits, less inpatient hospitalizations. All of those things are critical, and of course, connection to the community. Now, the number of peer crisis respites across the US is increasing, but the SAMHSA report found that securing sustainable funding can be a challenge. In addition, we found that, the funding requirements sometimes, like criteria and requests for proposals, sometimes conflict with the core principles of peer support. What do you think it will take to scale up or establish more peer crisis respites with fidelity to the core peer respite principles across the country?
There's a number of things. One is research. I think we deserve to have funding to really research all of the different respites and models in the country. And I say that because everyone does do it a little differently, but the core principles remain solid. We want people to have a better experience, an opportunity for wellness, a better quality of life, and that's the core of why we're doing this, to avoid trauma and avoid the traditional emergency rooms and crisis cares and whatever. So research is key, I think. The other is getting the states to understand what a respite really is, because in New York, I'd been running it for many, many years, and the state of New York became very interested in it and wanted to help fund it. And when they came out with their first RFP, fortunately, they asked, for some guidance, and it had to be totally rewritten because it would have been more of a traditional service. And so we had to make sure that it was voluntary, that people can come and go as they please, that it had these core values embedded in it, the training, everything that we did around it was then infused into it. And then as that evolved, it moved into the New York State looking at CMS to see how it could be Medicaid billable, which is a fear that many people have, because if you get into Medicaid, you get into medical notes and regulations and corporate compliance and all that stuff. But what we've learned here is that if you do it well and you do it right, you never lose your core. You never lose the core of why you exist. People don't get stuck behind a computer screen and having to talk to somebody. Nothing has changed, in that evolution of the funding systems. And then there are those that don't want to go into the Medicaid world, but find foundations and other funders that are willing to fund such great services as this. So there's really a blended and a braided amount of dollars that can be used and can be created to help respites, continue, grow and continue.
And if I can add to that, I would say after a lot of this research, a lot of the pieces too is just thinking more about mental health block grant dollars, earmarking funding in different states, looking at some of the issues and the disparities that exist for different communities as well, because I think sometimes accessing and reaching some of these places in rural communities is hugely challenging. For tribal lands, it can be hugely challenging. And I find that there are we need to address some of the barriers in reaching these different communities in terms of funding. Um, I think private philanthropy is huge. Per what Steve was saying earlier with foundations and a lot of that. I don't think that we've quite reached that space yet. But there are great opportunities once you have your peer run respite open from whatever financial funding stream you feel best suits your community. That then you can you could apply for arts and different foundation grants that could be specific to maybe art that you want to make as a community. You could apply for grants to build gardens. You could apply for a lot of different private philanthropy projects and grants that can support your peer and respite as well. So I think it takes time. I think there's a foundational need that we need support from public dollars to kind of get up and going. But then there's also need to talk more about peer run respites in the private sector.
Yeah, that's so important. The public dollars and then the blended and braided resources. I mean, it's definitely you're highlighting like how creative peer respite providers are to meeting the needs of the community and trying to reduce the barriers of access, but then again highlighting with more research and education about the core principles and staying true to the model really will help propel the access to more of these services throughout our communities. So thank you for highlighting them and for your leadership in ensuring that they really stay true to the needs of people in receiving the services. Now we know also moving on to there's addressing stigma, prejudice, and discrimination towards people with mental health and substance use challenges and our families are important issues to address and can give rise to not in my backyard, also known as NIMBY actions, NIMBYism, that can prevent access to these vital peer respite services. What have you done to engage your local communities to address NIMBYism when establishing such programs?
Yeah, we had to do a lot when people found out that there was going to be, when I first started, I called it a crisis residence or a crisis respite. I didn't call it just respite. And I found out, take the word crisis out, it makes it easier. But I know that in Nebraska and Georgia and other areas and in my areas, we had a big challenge on convincing the community that this was something that was worthwhile, that was safe, that was going to lend to helping the community serve their folks better. And some of it went to legal battles, and then some of it was just convincing and showing them how we do it and what we do. But it's a lot of relationship building, and that's really what it is building the relationships and building the trust so that people understand that the good of what a respite really is.
I know some of the ways in which we've addressed it. We attend town meetings. We've actually hosted town meetings in our peer run drop-in centers and spaces. So I think sometimes getting involved to that degree really quells some of that NIMBY mentality, if you will. I do think, to the point of what Steve was saying, a lot of people don't understand what it is. They don't understand that it's usually a residential permit, and that's how it's zoned in that city or town. So it's important to have those conversations too, because you are a part of that community when you're in that space. So.
And to add to that, that we do the same thing. It's really just connecting and allowing individuals to learn and educate. We have to really approach these situations as an opportunity to educate, and that's what we really try to do that. And getting politicians involved, getting providers involved, getting the community involved, and now when we first started, there was a lot of people that were like, oh no, and now I got women sneaking cookies over and when staff's backs are taken, they're giving cookies to the individuals in our respite program. So just takes time.
Definitely. And thank you all for your leadership, the wisdom you shared today, and the passion and commitment to offering the quality peer services to individuals in crisis. And you're helping break down barriers and increase access to these important services in times of crisis. So just really grateful for your support in this effort to elevate peer crisis respites. Now we'll move to the Q&A section of the agenda, moderated by my colleague, Steve Fry, who has been gathering questions that our audience have posted in the Q&A box to share with you. And thank you all again. Passing it on to you, Steve.
Thank you, Katara, and let's thank all our panelists for their great presentations today and responses. I think a lot of the questions that we've been seeing in the Q&A have either been answered in your remarks, but we do encourage people to also read the report. I'll start with kind of an easy one. We're calling the report, of course, Peer Crisis Respite. Steve, you mentioned what you call your programs. Do you have to be in crisis to use one of these programs?
You know, people determine what a crisis is in their, in their own perspective, their own realities. If they feel that they need support, they need help, we're not going to call it a crisis. We're going to call it whatever they want to call it. And if they want that support, they're welcome.
Yeah, similarly, we don't define crisis for them either. And I think it's really talking about how do we engage what you might be going through as like an opportunity for community and healing and having that connection. So yeah.
Thank you. Kim, you anything to add to that?
Same here. We do not define an individual's crisis. This is a space of wellness and love, and wherever your situation or state you're in is just what it is, and we're here to support you.
Thank you. Well, as a person with lived experience myself, I'd like to know if I'm a little shaky. I'd have a welcoming place to go. Obviously, we're getting a lot of questions about payment sources, funding sources. A lot of people were asking if there were financial projections, reimbursement codes. I remind people, this is a first attempt to gather some information and put it out for audience of funders and payers, and I'm glad there's so much interest in that detail. Among the 6 respondents who do take Medicaid, did we know if that's all they took? Or is it more likely they have multiple funding streams?
I'm one of those folks, so I can tell you it's multiple funding streams. That's why it's free for people that, that can't afford to come in or whatever. And the Medicaid is more for sustainability across the country, for folks to operate respites. Again, there's a lot of work that goes into how you do that, but no, I don't think I would never want to be. I never wanted to get into Medicaid, but when the state embraced it and made a state plan amendment with the CMS, it was an opportunity to make it very simple with just a couple of CPT codes and the simplicity of notes and sign-offs, and that's what allowed us to keep those values strong and accept the Medicaid. Otherwise, I wouldn't have gone in that direction.
And Vesper, you mentioned looking for alternative sources of funding everywhere you can go, right?
Yeah, absolutely. I mean, for us, we do not have Medicaid funding. We are funded through mental health block grant dollars that are brought down to the state. But I will say that we have diversified with a wide variety of grants that we're trying to add for different projects and things that the community might be interested in working on. And we usually determine a lot of the things that we want to fund as a community. So we have these meetings called community gatherings. Everyone gathers, we talk about different ideas, different things that we want to do. And then if the project can involve like one of our peer-run respites, we partner on it, we bring it together. I think by diversifying funding, you have the best chance of sustaining your peer-run respite. And I think in terms of arguments within the state, why they should fund peer-run respites, it's $6,000 a night for an emergency mental health visit in an emergency room. People often return to that emergency room. Whereas a peer-run respite for us, for example, it's anywhere between $175 to $300 something a night, not at a cost for the individual. It is free for the guest coming in, but it's a cost out of the overall program cost. And that is significantly different between a lot of inpatient environments and emergency rooms. So you would be saving the state dollars. I think that there's a significant point there to be made and shared.
Thank you, Vesper. And Cameo, you too, yours is relatively new. We have a number of questions like, well, how did you get your peer respite started? And was there evidence base? There's some, I encourage people to look at the references in the report and evidence base that you used to convince legislators or whoever you had to. Maybe you could tell us a little bit about that story.
Absolutely. And first, I want to say peer respite's best thing I've ever done. I just want to start there. Anybody who's interested in starting a peer crisis respite, you will be heavily fulfilled. It is not for the weak. You're going to have to chase the funds, but a little bit. But we have been blessed to be really supported by our state Department of Mental Health and getting some state opioid dollars, some opioid settlement dollars and block funding, as well as cannabis tax funds. We're a lot like Vesper. We also have to diversify our funds with working with hospital systems who, again, see the definitely see the need for respite and wanting to use our services versus having individuals come into the ED and ER. So we had to obviously use those things and diversify funds in that way. We are still working on getting some foundation dollars. But we have really been able to make such a mark in, again, being the first peer respite program in the state of Missouri. It was not an easy feat there, but it has been so well received by the community. And we're seeing legislators just really seeing the need for it and the results for it. Again, I bring up our Black men at the time were leading in overdoses at 81%. And since we've been open has dropped 40% since. So they see how the overdose rates has decreased. They see how money is being saved by individuals coming to respite versus being in the ED. So the need for investment is showing. It's there. So those dollars through the state of Missouri, as well as working with the hospitals, and then getting, attention from foundations is how we are looking to continue to sustain our respite program.
You just
Oh.
briefly add, we did get county legislators and legislations in 2 different counties to help fund the respites. And that was kind of unheard of. I never thought we'd get a county to embrace it so much that they wanted to help fund it. And I know that in Nebraska, we got the Lincoln legislation in the region to approve and fund them out there as well. So we did get, individual smaller local governments to support it as well.
So I guess one important thing is to continuously be marketing yourself, touting your accomplishments, and making that value-based argument. Not only is it more humane, it's more welcoming, it produces equal to superior outcomes, and it's just good for everybody all the way around. Okay, well, thank you all. I'm sorry we couldn't get to so many questions, but again, I think you covered a lot of it in your remarks. Encourage people to read the report, and I will send it back to Shoma to close us out.
Thank you. Thank you everybody for attending today's webinar. I encourage you to come visit the CFRI website at www.samhsa.gov/CFRI, CFRI, to download the full report so that you can see what's in there. And we just covered a smidgen of it today. I also encourage you to sign up for our next webinar on December 10th, and you can do that on the website as well. The slides and recording for this webinar will be on that CFRI website soon, and so you'll be able to download them there. And with that, thank you and have a wonderful rest of your evening.